Good morning, doctors. Today is our 22nd day of reading Oxford Handbook of General Practice. I'm a study buddy, Dr. Sesha, and we are preparing for MRCGP International AKT exam. So today we are at page number 459. Uh, the topic is wrist and hand problems. Let's start reading. For all hand injuries, check for if there is any nerve injury. Nerve injury can occur due to trauma or lacerations of the hand or wrist. Examine the sensory and motor function. Always ensure no other structures are damaged before suturing the skin wounds. Refer all nerve injuries for specialist assessment and management. Surgery can improve the outcome considerably in some cases. Intensive hand physiotherapy is important to regain function. Types of nerve injury. Neuropraxia, temporary loss of nerve conduction often caused by pressure causing ischemia. Axono, axonomesis, damage to the nerve fiber, but nerve tube is intact, and the chance of successful nerve regrowth and recovery is very high. Neurotemesis, divided nerve, lack of guidance to regrow fibrils gives decreased chance of good recovery, and neuroma may develop in neurotemesis. Median nerve damage. The median nerve controls the grasp. Damage causes inability to lift the thumb out of the plane of the palm. Abductor pollicis brevis failure and loss of sensation over the lateral side of the hand. Ulnar nerve damage. Injury distal to the wrist causes a claw hand deformity, loss of abduction and adduction of the fingers, and sensory loss over the little finger. Variable area of the ring finger. Radial nerve damage. The radial nerve opens the fist. Injury produces a wrist drop and variable sensory loss, including the dorsal aspect of the root of the thumb. Tendon injuries can occur due to attrition or laceration of the hand or wrist. Examine the hand function. Always ensure no other structures are damaged before suturing the skin wounds. Extensor or flexor tendons can be affected. Primary surgical repair is usually the treatment of choice in tendon injuries. Vascular injuries can occur due to trauma or lacerations of the hand or wrist. Check for perfusion, the temperature of the fingers, and examine the pulses. Ensure no other structures are damaged before suturing the skin wounds. Refer all the vascular injuries for specialist assessment and management. Work-related upper limb pain. Work-related pain in the arm plus wrist due to keyboard use. Overuse syndrome, often termed as repetitive strain syndrome or RSI. It's a diagnosis of exclusion. No physical signs will be there. Exclude other conditions, example carpal tunnel syndrome, tennis elbow, etc. Management. Reassure. The condition is curable. Continue to work but avoid aggravating activity. Liaise with work to ensure evaluation of workstation ergonomics. Yes, ergonomics in the workstation are a major cause for work-related repetitive strain injury or work-related upper limb pain. So that has to be evaluated. Gradually reintroduce activity. Physiotherapy may help. Explore psychological and work-related issues. A multidisciplinary approach is needed. Work-related upper limb pain is a notifiable industrial disease. Existence of repetitive strain injury has been challenged. Rigorous assessment often reveals undiagnosed cause of pain. Complex regional pain disorder, also known as reflex sympathetic dystrophy or algodystrophy. Pain plus vasomotor changes in the limb leads to loss of function. Most common in the hand and wrist but may occur in the lower leg or feet. Usually follows a trauma. But the trauma may be trivial and signs may appear for weeks or months later. Signs are pain at rest, exacerbated by movement and light touch, swelling, discoloration, temperature changes, abnormal sensitivity, sweating, and loss of function. So there will be pain at rest exacerbated by movement and light touch and swelling and discoloration. Temperature changes, sensitivity, abnormal sensitivity, and sweating and loss of function in the limb. X-ray may show osteopenia. So other than osteopenia, the X-ray will be perfectly normal. But these are the signs you will be able to elicit. Management. Physiotherapy improves the prognosis if started early. Analgesia, NSAIDs, opioids, and nerve painkillers can be given. Refer to pain clinic or rheumatology for specialist treatments. Example, a nerve block or a spinal cord stimulation or a CBT or a graded motor imagery. Tenosynovitis. Inflammation of the tendon sheet, often due to unaccustomed activity like gardening, may affect the extensor or the flexor tendons. Pain is often worse in the morning, presents with swelling and tenderness over the tendon sheet and pain on using the tendon. Treat with rest and NSAIDs. If not settling, an injection of steroid into the tendon sheet may help. Notifiable industrial disease if work-related tenosynovitis. Decurrence tenosynovitis. Tenosynovitis of the thumb extensor and abductor tendon sheaths, pain over the radial styloid process and on forced adduction and flexion of the thumb. So there is a pain over the radial styloid on the opposite action, that is adduction and flexion of the thumb. Treat with the thumb splint plus local steroid injection. Refer not settling, if not settling. Carpal tunnel syndrome. Pain in the radial 3.5 digits of the hand, plus or minus, numbness, pins and needles, and thenar wasting due to compression of the median nerve as it passes under the flexor retinaculum. It is worse at night. The symptoms are improved by shaking the wrist. Associations: pregnancy, hypothyroidism, diabetes, obesity, carpal arthritis. Hypothyroidism, diabetes, obesity, and carpal arthritis. Investigations. The Phelan's test. In carpal tunnel syndrome, Phelan's test is, we do the Phelan's test. This is hyperflexion of the wrist for 1 minute triggers symptoms. Tinel's test. Tapping over the hyperflexion of the wrist reproduces the symptoms. Tinel's test is tapping over the carpal tunnel causes paresthesia. Request nerve conduction studies if diagnosis is in doubt. Management. GP treatment. Night splints may help plus carpal tunnel steroid injections. Management. GP treatment. Night splints may help plus or minus carpal tunnel steroid injections. So at primary care level, we are supposed to give night splints and carpal tunnel steroid injections. Less likely to help if the age is more than 50 years or symptoms are more than 10 months old. If GP treatment fails, constant paresthesia or triggering of fingers, refer to the orthopedic division for flexor retinaculum. Clean box disease. The lunate bone develops patchy necrosis after acute or chronic injury. The patient is usually a young adult complaining of aching and stiffness of the wrist. Examination. There is tenderness in the center of the back of the wrist plus limitation of the wrist extension, and X-ray is normal at the first instance, but later it shows increased density of the lunate plus a deformity. Refer for orthopedic opinion. Osteoarthritis in the hand. So in the hand, the major markers of osteoarthritis are Herbergen's nodes, swelling of the distal interphalangeal joints, no treatment is required, and Bouchard's node, swelling of the proximal interphalangeal joints, no treatment is required. So Bouchard's is swelling of the PIPs and Herbergen's is swelling of the DIPs. First, carpometacarpal. First, carpometacarpal osteoarthritis or pain or swelling at the base of the thumb. This is more common in the hand. So thumb becomes stiff. A splint or steroid injection can be helpful. If the pain persists, surgery, trapeziectomy may help. Dupuytren's contracture. Palmar fascia contracts, so the fingers, typically the right fifth finger, cannot extend. In Dupuytren's contracture, the palmar fascia contracts, so typically the right fifth finger cannot extend. Right hand side, fifth finger cannot extend. So prevalence is 10% in males more than 65 years if there is a family history. Less common in women. Associations are smoking, alcohol, heavy manual labor, trauma, diabetes, phenytoin, Perion's disease, AIDS. Often simple reassurance suffices. Ultimately, referral for surgery, fasciotomy or fasciectomy may be needed. So drugs that cause Dupuytren's contracture is phenytoin. Otherwise, diabetes, alcohol, smoking. Perion's disease is one in which there are some fibrous tissue in the penis also. So that's also associated with fibrosis in the fascia, palmar fascia. Trigger finger. Nodules on the tendon can occur spontaneously and in diabetes and rheumatoid arthritis. Trigger finger more common in diabetes, rheumatoid arthritis or spontaneously. Nodules on the tendon most common in the ring finger and the middle fingers. So it is most common in the ring fingers and middle fingers. This concept has also been tested. The nodule can be palpated moving with the tendon. It is moving along the tendon. Pain in triggering the finger is fixed flexion and needs to be flicked straight by the other hand. Occurs because the nodule jams the tendon sheet. Management, local steroid injection or refer to surgical release. Finger fractures will be discussed in page 1093. Mallet finger. The fingertip droops due to avulsion of the extensor tendon as an attachment to the terminal phalanx. So the fingertip droops because there is avulsion of the extensor tendon attachment to the terminal phalanx. Refer for an X-ray. Management, a plastic splint which holds the terminal pharynx in extension is worn for 6 weeks to help reunion, must not be removed. Arthrodesis may be needed if healing does not occur. Gamekeeper thumb. Forced thumb abduction causes rupture of the ulnar collateral ligament. It is forced thumb abduction causes rupture of the ulnar collateral ligament, can occur on wringing a pheasant's neck, example, hence the name, or more commonly by catching the thumb in the matting on a dry sky rope. The thumb is very painful and pincer grip is weak. Refer open surgical repair in most effective treatment. So gamekeeper thumb is a sports injury and you need to refer it for surgical repair. Avulsed nail. Protect the nail bed of an avulsed nail with soft paraffin and gauze and check the tetanus status and give antibiotic prophylaxis flucloxacillin 500 mg QDS for 7 days. Partially avulsed nails needs removing under ring block to exclude an underlying nail bed injury. Okay. The nail is replaced to act as a splint to the nail matrix. Subungual hematoma. The blow to the finger can cause bleeding under the nail, very painful due to pressure buildup. Relieve by trephining a hole through the nail using a 19 gauze cream color needle. No force required. Just twist the needle as it rests vertically on the nail or a heated point example of a paper clip or a cautery instrument, of benefit up to second day after the injury. Okay, so you have to release the hematoma by drilling a hole into the nail with a 19 gauge needle or a cautery tip or a paper clip. Polydactyly. Extra digits can vary from small fleshy tags to complete duplications. They may be isolated defect or associated with syndrome. Small fleshy tags are removed in the first few months. For extra digits firmly fixed or involving tendons or joints, surgery may be delayed until the child is more than 1 year. Refer to orthopedics or plastic surgery. Syndactylity. Digits may be joined by a web of skin or more firmly fused. Webbing is usually mild and treatment is for cosmetic regions if at all. Where the digits are fused, separation and skin grafting is carried out at near about 4 years of age. Refer for plastic surgery. Hip and pelvis problems. So, whereas in polydactylity, the extra digit or uh, firmly fixed involving tendons, joints, and surgery is delayed until the child is more than 1 year age, whereas in syndactylity, where the extra digits are fused, separation and skin grafting is carried out at around 4 years. Hip and pelvis problems history. Pain on walking, pain at rest. Is there pain on walking? Is there pain at rest? Hip joint pain is usually felt in the groin. Referred pain is often felt in the knee. Hip disease results in reduction in walking distance, difficulty in climbing the stairs and getting out of low chairs. Examination. Look, watch the patient walk. Look. Watch the patient walk, hip disease, limp or a waddling gait. So, examination of a hip or pelvic problem. So you have to look at the patient, watch the patient walk. If there is a hip disease, there will be a limp or a waddling gait. Feel. Feel for any joint tenderness is distal to the midpoint of the inguinal ligament. So move. Passive movement with patient lying supine. Check the range of movement. Pain is reproduced on movement. Is the pain reproduced on movement? Crepitus is present. Measure. Measure the hip distance is often, measure. Hip disease is often associated with shortening of the affected leg. True leg length, anterior superior iliac spine to the medial malleolus. Apparent leg length, umbilicus to the medial malleolus. Trendelenburg test. Ask the patient to stand on one leg and lift the foot on the contralateral side of the ground. Place your fingers on the anterior superior iliac spine. If the pelvis sags on the unsupported side, then it's a positive Trendelenburg sign. The hip on which the patient is standing is painful or has weak or mechanically disadvantaged gluteus medius. So, if the pelvis sags on the unsupported side, the hip on which the patient is standing is painful or has a weak mechanically disadvantaged gluteus medius. It is false positive in 10%. Malignancy. The hip and pelvis are common sites for secondary malignancy. So, pain is severe and unremitting, day and night pain, often accompanied by weight loss. X-ray may show no abnormalities or reveal a lytic or sclerotic deposits. Bone scan is diagnostic but may miss a myeloma. Depending on the clinical circumstances, either refer for a specialist advice, oncologist, radiotherapist, or a palliative care. Treat with analgesia. Meanwhile, high risk of pathological fractures. Osteoarthritis of the hip is a major cause of hip pain and disability. Incidence increases with age. Males more than females. In males the incidence is similar to females. Predisposing factors: past hip disease, example there's a Perthes disease or trauma. Unequal leg length. Presentation: The pain may be diffuse and felt in the hip region, thigh or knee, relieved by rest in the early stages of disease. Signs: reduction in internal rotation and abduction of the hip with pain at extremes of movement, antalgic gait, eventually fixed flexion of the hip. So the presentation in osteoarthritis may be: pain may be diffuse, felt in the hip region, thigh region or knee region, relieved by rest at early stages. Signs which we can elicit are: there is reduction in internal rotation and abduction of the hip with pain at extremities of movement. Internal rotation, abduction of the hip with pain at extremes of movement. Antalgic gait, eventually fixed flexion of the hip. Antalgic means painful gait and fixed flexion of the hip. Investigation. X-ray may confirm the diagnosis but is often not needed. There is poor correlation between X-ray changes and pain felt. Perform Oxford hip score, which is given in figure 14.3. Causes of pain around the hip. Pain, there is buttock pain. So polymyalgia rheumatica. Buttock pain, causes of buttock pain is polymyalgia rheumatica, sacroiliitis, vascular insufficiency referred from the back. Groin pain, hip joint disease, osteoarthritis, rheumatoid arthritis, Paget's disease, osteomalacia, fracture, osteitis pubis, hernia, psoas abscess. Groin pain is due to so many other causes. Could be a fracture, osteitis pubis, hernia or psoas abscess. Lateral thigh pain, trochanteric bursitis. When the pain is in your question is in the lateral side of the thigh, then it's a trochanteric bursitis. Referred pain from the back, enthesitis, spondyloarthropathies, gluteus medius tear, meralgia paresthetica, fascia lata syndrome. So, Oxford hip score. This is the Oxford hip score, figure 14.3. Let us just read the questions. So during the past 4 weeks, how would you describe your pain pain you usually have from your hip? None, very mild, mild, moderate, severe. Severe is 0 and no pain is 4. Okay, this is the opposite grading system. Impossible to do is 0, no trouble at all is 4. So activity levels and no pain is marked higher than inactivity level and severity. If more severe is 0. During the past 4 weeks, have you ever had trouble washing and drying yourself all over because of your hip? During the past 4 weeks, have you had any trouble getting in and out of a car or using a public transport because of your hip? During the past 4 weeks, have you been able to put on a pair of socks or stockings or tights? During the past 4 weeks, could you do the household shopping on your own? During the past 4 weeks, how long have you been able to walk before pain from your hip becomes severe? During the past 4 weeks, have you been able to climb on a flight of stairs? During the past 4 weeks after a meal, how painful has it been for you to stand up from a chair because of your hip? During the past 4 weeks, have you been limping when walking because of your hip? Have you had any sudden severe pain, shooting, stabbing or spasms from the affected leg? How much pain from your hip interfered with your usual work including household work? Have you been troubled from pain from your hip at bed or night? So these are the 12 questions in Oxford hip score. So management of hip osteoarthritis. Analgesia. Regular paracetamol, NSAIDs, education, weight loss, exercise, cycling or swimming. We are promoting cycling and swimming. Correction of unequal leg length. Walking stick plus shock absorbing shoe insoles can help. Consider referral for physiotherapy. Muscle strengthening exercises may reduce the pain or Oxford hip score pain or Oxford if Oxford hip score is less than 20. If the hip score is less than 20 means it is severe, and refer refer for physiotherapy for muscle strengthening exercises, and if Oxford hip score is less than 20, then refer to orthopedics for hip injection or replacement. Total hip replacement. More than 90% achieve good result. Most last more than 15 years. Post-op care. Risk of dislocation is in the first 6 weeks. Advised to avoid crossing the legs, taking care with transfers, using walking stick. No driving for 6 weeks. Physiotherapy is usually arranged via secondary care. Hip dislocation occurs in the front seat passengers in cars accidents as the knee strikes the dashboard. Reduction under anesthetic is required. Greater trochanteric pain or bursitis can mimic positive coexist with hip osteoarthritis, may be associated with muscle weakness around the hip. Diagnosis: point tenderness over the greater trochanter. So this is a lateral hip pain, greater trochanteric pain, trochanteric bursitis, can mimic with or can coexist with osteoarthritis, may be associated with muscle weakness around the hip. Diagnosis: there is a point tenderness over the greater trochanter. Management: consider local steroid injection if trochanteric bursitis is likely. Refer to physiotherapy to strengthen the hip musculature to prevent recurrence. Meralgia paresthetica: burning and numbness in the upper lateral aspect of the thigh due to compression of the lateral cutaneous nerve of the thigh. Risk factors are pregnancy, obesity, diabetes. Examination: extension of the hip or deep palpation just below the anterior superior iliac spine provokes symptoms. Treatment: analgesia including neuropathic painkillers, TENS plus local steroid injection. Rarely surgical decompression is needed. Fascial lata syndrome. Inflammation of the fascial lata causing pain in the lateral thigh, often due to overuse or weak musculature. Treatment is with rest plus referral to physiotherapy. Hip infection. Present with a hip pain and weight loss and night sweats and rigors. Be aware of the infection in patients with rheumatoid arthritis. So, rheumatoid arthritis, hip prosthesis, or immunocompromise are the risk factors for hip infection. Refer for investigations. X-rays are often unhelpful. Bone scan is non-specific. Admit for an ultrasound-guided drainage, bed rest, and IV antibiotics. You need to admit this patient with a hip infection. Avascular necrosis may present with a hip pain and have high levels of suspicion in patients with risk factors. So, avascular necrosis may present with hip pain, have a high suspicion in patients with risk factors like SLE, sickle cell disease, high alcohol consumption, pregnancy, steroids. X-ray or bone scan may confirm the diagnosis, but MRI is most sensitive. Specialist management is needed, usually progress to cause osteoarthritis. Pubic symphysis dehiscence. Painful condition occurring in late pregnancy, may persist after delivery. The pubic symphysis separates, resulting in low abdominal pain radiating down both thighs plus low back pain. The pubic symphysis separates, resulting in low abdominal pain radiating down both the thighs and low back pain, lower abdominal pain and low back pain is pubic symphysis dehiscence. Pain is constant and worse on movement. It resolves on rest. Examination reveals a soft abdomen and obstetric examination is normal. Advise simple analgesia, example paracetamol. Rest in a semi-recumbent position when pain. Refer for physiotherapy, especially if still a problem in the puerperium. Most resolve spontaneously within several months of delivery. Some persist and need specialist referral. The limping child. If a child is limping, take it seriously. Look for a problem. Children find it difficult to localize pain. Pain can be referred from the hip to the knee. Examine the whole limb carefully. . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . Children find it difficult to localize pain. Pain can be referred from the hip to the knee. Examine the whole limb carefully. Other causes of referred pain include spinal pathology, psoas spasm, from the GI pathology, example appendicitis. Limping without pain is uncommon and may be due to undiagnosed developmental dysplasia of the hip. Okay, transient synovitis of the hip. The most common reason for limping in childhood, peak age is 2 to 10 years. Males more than females. The child is usually well but complains of pain in the hip or the knee and may refuse to weight bear. So, often occurs after a viral infection, cause is unknown, excludes septic arthritis, refer to orthopedics, usually resolves in 7 to 10 days without treatment. Perthes disease. Perthes disease or pain in the hip and knee and limp limited to hip movement developing over 1 month's time. It's not acute. It's a gradual onset due to avascular necrosis of the femoral head, bilateral in 10% cases, peak age is 4 to 7 years, range is 3 to 11 years, males more than females 4:1. Management. If you suspect, refer for an X-ray and to the orthopedics. Treatment is with rest, X-ray surveillance, bracing or surgery depending on the severity. Usually heals over 2 to 3 years. Joint damage may cause early arthritis. Risk factors for poor outcome include female sex is a risk factor because mostly it is common in males, but if females are affected, it's a risk factor for poor outcome. Onset more than 8 years of age. Involvement of the whole femoral head. Pronounced metaphyseal rarefaction. Lateral displacement of the femoral head. So there is involvement of the whole femoral head by pronounced metaphyseal rarefaction and lateral displacement of the femoral head. These three are poor outcome, indicators of poor outcome. In Perthes disease, slipped upper femoral epiphysis. The upper femoral epiphysis slips with respect to the femur, usually in the posterior inferior direction, bilateral in 20% of the cases. Incidence is 1 in 1 lakh. Peak age is 10 to 15 years. More common in males than in females, 3:1. Typically affects the obese, underdeveloped child or tall, thin boys. So it can either be obese and underdeveloped children or tall and thin boys also. Either way. Presentation. Pain at rest in the groin, hip, thigh, refer to the knee, limp or pain on movement, decrease in hip movements, particularly abduction and medial rotation. So the affected leg may be externally rotated and shortened. Management. Confirm with an X-ray including lateral view, show backward and downward slippage of the epiphysis, refer to the orthopedic, surgical pinning or reconstructive surgery is needed. Monitoring of the other hip is essential. Complications include avascular necrosis, coxa vara, early osteoarthritis, slipped epiphysis on the contralateral side. Developmental dysplasia of the hip, page 834. You will read it later. So these are the childhood hip diseases, causes of limping in a child. So transient synovitis, the age group is 2 to 10 years, whereas Perthes disease is in a younger age group, 4 to 7 years, and range is 3 to 11 years, around the same range, and slipped upper femoral epiphysis is seen in adolescent age group, that is 10 to 15 years. So age is also one thing that you can consider for the diagnosis. Of course, other risk factors. Knee problems, page number 466. History. Trauma. History of injury. Ask about the degree and direction of force in knee problems. Pain or stiffness. Attempt to distinguish well-localized mechanical pain and diffuse inflammatory or degenerative pain. Deformity. Swelling. If injury, time of onset of swelling in relation to the history, immediate effusions suggest hemarthrosis, post-traumatic effusions appear later, knock knees or bow legs if they are present. Function. Do the Oxford knee score test. So that was first was the Oxford hip score and this is Oxford knee score. If Oxford hip score is more than 20, is less than 20, then it is you need to refer to a surgeon. Similarly, let us see when we come to Oxford knee score in figure 14.4. Examination. Always compare both the knees. Look. Watch the patient walk. Look at the knees while standing, varus or valgus deformity. Ask the patient to lie down. Note the quadriceps wasting, scars, skin changes, swelling and deformity. A space under the knee viewed laterally suggests a fixed flexion deformity. With the legs extended, lift both the feet. When you ask the patient to lie down, if there is a space between the bed and the knee, when you are viewing laterally, it suggests a fixed flexion deformity. With legs extended, lift both the feet off the bed to demonstrate hyperextension. Feel. Feel the quadriceps for wasting and palpate the knee for warmth. Check the joint line, collateral ligaments. Feel for the warmth, check the joint line, check the collateral ligaments, check the tibial tubercle, femoral epicondyles for tenderness. Palpate the popliteal fossa for a Baker cyst. Check for an effusion. Test for patellofemoral lesions by sliding the patella sideways across the underlying femoral condyles. Move. Move with the patient lying. With the patient lying on his back. Check active or passive range of movement. Pain reproduce on movement. Crepitus. Test the medial and lateral collateral ligaments and cruciate ligaments. Okay, you need to check the lateral collateral ligaments and the cruciate ligaments when the patient is in lying down position. Measure. Quadriceps diameter. Measure the quadriceps diameter 18 cm up from the joint line in adults. Knee pain can be referred from the hip, so examine the hip well. Osteoarthritis of the knee. So this diameter you check bilaterally, and if there is any wasting on one side, that is also something you need to evaluate. Osteoarthritis of the knee is very common. X-ray evidence of osteoarthritis is even more common. Treatment. Education. Glucosamine, analgesia, paracetamol plus NSAID. Exercise, refer to physiotherapy. Suggest using a walking stick. Steroid injections can be helpful in some patients. If pain and disability are severe, that is Oxford knee score is less than 16, refer to orthopedics for consideration of total or partial knee replacement. So in Oxford knee score less than 16, you have to refer to orthopedics for consideration of knee replacement. Whereas in hip score less than 20, you need to refer to surgery. Knee replacement is very successful procedure resulting in decrease in pain and increase in mobility. 95% processes last more than 10 years. Infection in the knee joint. Most commonly infected joint is the knee joint. Signs: hot, red, swollen, painful knee. Differential diagnosis is Rita's disease is chlamydial, post-chlamydial infection, arthritis of the joints. Gout, so could be due to Rita's disease, gout, pseudo-gout, and traumatic effusion or rheumatoid arthritis. So these are the systemic conditions which can lead to painful knee. If infection is suspected, refer to an emergency to rheumatology or orthopedics for investigation. Do not give antibiotics until the joint has been aspirated. So whenever you think there is a septic arthritis of the knee joint, do not give antibiotics until they have aspirated the knee joint. Non-traumatic knee effusion. Common causes are gout. So there was no trauma, but there is an effusion in the knee. So it could be gout, rheumatoid arthritis, calcium pyrophosphate dehydrate disease, that is pseudo-gout, spondyloarthropathies including reactive arthritis. So the same conditions which were listed above but as differential for septic arthritis. So they can cause non-traumatic knee effusion. Consider for FBC, ESR, rheumatoid factor, anti-nuclear antibodies, LFTs, bone biochemistry, and thyroid function tests. Drain the effusion and refer to rheumatology to drain. Send the fluid for polarized light microscopy for crystals and microbiology for infection. Management. If no infection, inject with long-acting steroid. Recurrent and no cause found, then refer to rheumatology. Iliotibial band syndrome. We'll see in page 477. So this is the Oxford knee score. Again, during the past 4 weeks, how do you describe the pain you usually have from your knee? Mild to severe. None, mild to severe. During the past 4 weeks, have you had any trouble washing and drying yourself because of your knee? Have you had any trouble getting in and out of the car or using public transport because of your knee? How long have you been able to walk before pain from your knee became severe, with or without a stick? After a meal, how painful has it been for you to stand up from the chair because of your knee? Have you been limping when walking because of your knee? Could you kneel down and get up again afterwards? Have you been troubled by pain from your knee in bed at night? So, and last, no, two more questions. How much pain from your knee interfered with your usual work, including household work? Have you felt that your knee might suddenly give away or let you down? Could you do the household shopping on your own? Could you walk down one flight of stairs? So these are 12 questions of the Oxford knee score. So bipartite patella. Detected on X-ray, usually asymptomatic incidental finding but can cause pain due to excessive mobility of the patellar fragment. If troublesome, refer for fragment excision. Patellar dislocation. Lateral dislocation of the patella and tearing of the medial capsule or quadriceps can occur due to trauma, more common in young people, and if joint hypermobility syndrome is present. Patient is in pain and unable to flex the knee. Okay, refer via accidents and emergencies or orthopedic for reduction. So this is the lateral dislocation due to trauma to the medial capsule or the quadriceps. And younger people, joint hypermobility syndromes is a common cause. Refer to accident and emergency for reduction. Recurrent subluxation of the patella. It causes medial knee pain. The knee gives away due to lateral subluxation of the patella. It is most common in girls with valgus knees. Associated with familial hypermobility syndromes, high riding patella. These are the associations with recurrent subluxation of the patella. Signs are increased lateral patellar movement and positive apprehension test, pain and reflex contraction of the quadriceps on lateral patellar pressure. Refer to physiotherapy for vastus medialis exercises. If that is unhelpful, refer to the rheumatology to exclude a hereditary connective tissue disorder and to orthopedics for consideration of lateral retinacular release. So in this case, when there is lateral subluxation, you are releasing the lateral retinaculum. Patellar tendinitis. Small tear in the patellar tendon causes pain, most commonly in the athletes. Differential includes inferior patellar pole enthesitis, spondyloarthropathies, fat-packed syndrome, anterior cartilage lesion, and bursitis. Diagnosis is with ultrasound. Treatment is with rest, NSAIDs plus steroid injection around, not into the tendon. Bursitis. Prepatellar bursitis or housemaid's knee is associated with excessive kneeling. Vicar's knee, infrapatellar bursitis, is associated with upright kneeling. Avoid aggravating activity. Aspirate plus so avoid the aggravating activity, and aspirate plus or minus steroid injection decreases the recurrence. If infected, treat with antibiotics and refer for drainage. Baker's cyst is a popliteal cyst. Herniation of the joint synovium can cause swelling and discomfort behind the knee, usually caused by a degenerative knee. Rupture may result in pain, swelling in the calf, mimicking a DVT. Rupture may result in pain and swelling in the calf, mimicking a DVT. Treat the underlying knee synovitis. Surgical cyst removal may be necessary if persistent problems are there. Collateral ligament injury. Common in contact sports. Causes are knee effusion if severe. Causes knee effusion if severe. And plus tenderness over the injured ligament. So medial collateral ligament or lateral collateral ligament, whichever one is injured, there will be tenderness over the ligament and there will be knee effusion. Collateral ligaments provide lateral stability to the knee. Normally, there is less than 5 degrees of movement. If more than 5 degrees of movement, the ligament may be ruptured. Treat with rest, knee support, analgesia. Refer to orthopedics if rupture is suspected. Cruciate ligament injury. Cruciate ligaments provide anterior posterior knee stability. Assessment can be difficult. Anterior cruciate tears result from a blow to the back of the tibia plus rotation where the foot is fixed on the ground. Signs. Signs. Effusion and positive draws test. So positive draw test. Supine with foot flexed at 90 degrees, fixed and knee at 90 degrees. Pull the tibia forward. Anterior drawers test, and test is positive if tibia moves forward on the femur. Posterior cruciate tears caused when the knee hits the dashboard in car accidents. Reverse drawers test is positive. Supine with knee at 90 degrees, apply pressure to push the tibia backwards. The test is positive if tibia moves backward on the femur. So anterior cruciate ligament tears are more common as sports injuries, and posterior cruciate tears are only seen when there is any car accident and dashboard injuries. Management. Refer to orthopedics if suspected, and splinting and then physiotherapy helps most cases 60%, but some require reconstructive surgery. Consider urgent referral if keen sportsman. Chondromalacia patellae. Common in teenage girls. Pain on walking up or down the stairs on prolonged sitting. So this is common in the teenage girls. Chondromalacia patellae is there will be pain on walking up and down the stairs or prolonged sitting. Signs. Pain on stressing the undersurface of the patella. Arthroscopy, indicated only in severe cases, reveals a degenerative cartilage on the posterior surface of the patella. Treat with analgesia plus physiotherapy. Vastus medialis strengthening decreases the pain in 80% of the cases. If persistent, exclude spondyloarthropathy and refer to orthopedics for arthroscopy. Osgood-Schindler disease. Seen in athletic teenagers, pain and tenderness and swelling over the tibial tubercle. X-rays are not required. Avoid aggravating activities. Usually settles down over a few months. If not settling, refer to orthopedics or rheumatology for further assessment. Bow legs and knock knees in children. Here there is tibial tubercle problem. Osgood-Schindler. Bow legs and knock knees in children. Genu varum or bow legs. Outward curving of the tibia, usually associated with internal tibial torsion. Except in severe cases, always resolve spontaneously. Severe cases may raise the possibility of rickets or rare developmental disorders. Refer for orthopedic opinion. Genu valgum or knock knees. Common among 2 to 4-year-olds, innocent if symmetrical and independent of any abnormality. Severe progressive cases suggest rickets. Refer for an X-ray. Loose bodies in knee may result in locking of the joint or effusion. Causes are osteoarthritis, chip fractures, osteochondritis dissecans, synovial chondromatosis. If problematic, refer for removal. That's because they result in locking. Whenever the foreign body is the moving small foreign body is in between the articular surface of the joint, it will result in locking. Osteochondritis dissecans. Necrosis of articular cartilage and underlying bone can cause loose body formation. Cause is unknown. Seen in young adults. Pain after exercises and intermittent knee swelling plus locking. Predisposes to arthritis. Refer for expert management. So there is pain after exercise, intermittent knee swelling plus locking. It predisposes to arthritis. Refer for expert management. Meniscal lesions. Twisting with the knee flexed can cause um, medial bucket handle meniscal tears, and adduction with internal rotation can cause lateral cartilage tears. Okay, twisting with knee flexed and then adduction with internal rotation can cause lateral cartilage tears. Symptoms and signs. Locking of the knee. Extension is limited due to cartilage fragment lodging between the condyles, giving way of the knee. Tender joint line is important for meniscal lesions. Positive McMurray's test. Rotation of the tibia over the femur with flexed knee followed by knee extension causes pain and click as trapped cartilage fragment is released. Reliability of this test is debated. Management. Refer for a post MRI plus arthroscopy treated by removal of the torn meniscal fragment. Meniscal cyst. Pain plus swelling over the joint line due to meniscal tear. Lateral cysts are more common than medial. The knee click may give way. Refer for arthroscopy. Removal of damaged meniscus relieves pain. Ankle and foot problems. So here we are done for today's class, and tomorrow we will continue from page number 470, ankle and foot problems, musculoskeletal problems. Thank you. Have a good day.